Greetings. So, in this lecture, we'll talk about rheumatoid arthritis. So, again, we look at rheumatology, and within that, we talked about arthritis, which was a pain with signs and symptoms of inflammation. So, you'd have swelling, redness, heat, you know, uh, and we divided it into acute and chronic. And with chronic, if you have more number of joints that are involved, one of the things that comes to mind is rheumatoid arthritis. So if we were to look at it, again, it's polyarticular, more than one joint, inflammatory. It's symmetrical. Again, it's got a chronic course with flares, okay? And then again, it's autoimmune. So again, the immune system acting against self. Uh, and it's more common in females, of course, because autoimmune diseases in general are. Okay. So let's talk about how it comes to pass. We don't know. We just know that there's some genes or genetic features that makes people susceptible. And then there's some environmental factors that cause those genes to get expressed. Um, we have a protein in our body, arginine, and in some people, for some reason that we're not sure about, this protein gets converted to citrulline. Okay, and this citrulline um, gets tagged or gets identified by the immune system as a bad actor. And the immune system makes antibodies to the citrulline that's anti-CCP or anti-cyclic citrullinated peptide. Okay, how does it do that? You have, again, remember the antigen presenting cells, and they attach themselves to, uh, they look at what they consider as foreign, and then they present these antigens right here to the T helper cells. So again, you have the antigen, and then you have the T helper cell receptor, which connects. And then, of course, T helper cell is a CD4 count, and antigen presenting cell is a MHC2 cell. So the CD4 attaches to MHC2. Remember rules of 8. If you're not sure, look at the anatomy and physiology video for this. Okay. And then, of course, there's a uh, co-stimulatory mechanism. And once this is locked and loaded, you get two responses. You get a humoral response, where you start to have antibodies, such as anti-CCP, come to pass. And again, you have you have cell-mediated immunity, where you have neutrophils and macrophages that are attracted to the site that cause inflammation. Okay, this cell-mediated immunity is type 4 hypersensitivity. If you're not sure, review the hypersensitivity lecture, where I've discussed it in detail. And essentially, you start to have inflammation. Okay, start to have inflammation, and you have inflammation specifically in the joints. And so, when we are looking at joints, again, you have joints. So there's bone, right? right? And then there's synovial membrane, and then there's cartilage. This in particular affects joints which have synovial membrane, and what this does is it causes an attack on the synovial membrane, an inflammation on the synovial membrane. Okay, this attack, this inflammation over time leads to granulation tissue being formed, which is called pannus. Once that tissue is formed, it starts to deform the joint. So you have, that's issue one, pannus formation, which again is very specific to rheumatoid arthritis, which causes deformity. Additionally, it eats up the bone, so you'll start to see bony erosions and osteopenia. So that's what you get to see on x-rays. Okay. Now there's some specific features to this disease. So it spares DIP, or the distal interphalanges. So if you have patient comes in, right, and then they say, hey, I have arthritis and here my DIP is inflamed, you can pretty much rule out rheumatoid arthritis. Okay, it affects the small joints of the hands and feet except the distal joints. Okay, so that's two. That's how you differentiate it from diseases like osteoarthritis, which tend to be more prevalent in the IPs and joints which are distal. Okay. Additionally, I remember Herbendine's and Buschardt's notes. Here you have swan neck deformity and boutonniere's deformity. Swan neck would be the PIP is flexed. DIP, sorry, is flexed. And in boutonniere's, the PIP is actually flexed. So swan's neck actually looks like swan's neck, the DIP being flexed. Okay? And those two are what I call important. The other thing that's really important is AM stiffness or morning stiffness greater than 1 hour. So you'll see in questions, you'll see this, you'll see swan necks, boutonnieres, and you'll see sparing of DIP. Okay. So that's joints. Now it has some systemic symptoms as well. Let's take a look at it. So again, fever is one of the constitutional symptoms, and an important one. Patients that are coming in with new onset carpal tunnel syndrome, patients who have anemia of chronic disease, that's normocytic, normochromic, and we'll talk more about it in anemias and hematology. Okay. Rheumatoid nodules. Okay. So these are really, really important. Then you have some of the other ones which are there, like inflammation of any layer of the heart, vasculitis. In lungs, you can have pleuritis or interstitial lung disease. You can have conjunctivitis and dry eyes in the eyes, and then glomerulonephritis. But again, in test questions, they focus more on fever, rheumatoid nodule, carpal tunnel, and anemia of chronic diseases. Okay. Okay. So now we had symptoms, right? We know exactly things that these patients come in with. Okay. So how do we diagnose this? Generally, questions um, and trends and epidemiology of this generally focuses more Caucasian patients. Remember lupus? Lupus favored more minorities, African Americans. This one, rheumatoid arthritis, favors Caucasian. Again, more in females and age 40 to 50. Okay. So they come in with a chronic history greater than 6 weeks of inflammatory arthritis, which is symmetrical in small joints of hand and feet. That's the most common presentation, especially on a question, with no involvement of DIPs or distal phalanges, okay, or distal joints. Again, morning stiffness greater than 1 hour. And then they'll start to add some stuff, rheumatoid nodules, anemia of chronic disease, you know, a carpal tunnel, start to add on or pile on stuff on that diagnosis. The provider may choose to do an x-ray. So early findings may be erosive, uh, you know, findings on the bone. That's early and no narrowing of the joint. Late findings may be pannus, the granulation tissue. But by then the deformity has set in. Again, we talked about rheumatoid nodule. Okay. Blood tests. You can do ESR and CRP, specifically CRP. It's going to be elevated, especially if they are in a flare. Joint fluid may be inflammatory. Can't be septic because it's not infectious. Okay. Why would you do a joint arthrocentesis? Okay. If again they may come in and they may present with inflammation of a couple of joints and you're not sure. Okay. But generally we don't because this doesn't, it's symmetrical, so it doesn't, you'd have two joints at least that are involved. Okay. But then there are two tests that are specific to rheumatoid arthritis. There's rheumatoid factor and anti-CCP. Again, rheumatoid factor's cheap, anti-CCP is more expensive. Rheumatoid factor is not specific but sensitive for inflammation. So you can have several people that don't have rheumatoid arthritis that have a positive rheumatoid factor. But it's a useful test. If I suspect somebody of having rheumatoid arthritis and they are negative rheumatoid factor, chances are it's not rheumatoid arthritis. Anti-CCP is actually very specific for rheumatoid arthritis. It's just not very sensitive or very common. But once you find it, you got your diagnosis. In fact, it's so specific that the patient may not have some of these symptoms of rheumatoid arthritis, but this positive means they're on their way. Okay. So, clinical course. Generally, the clinical course is you have flares and then you have inflammation baseline. Flares, inflammation baseline. Flares, and then your inflammation baseline can go up. Or it could be progressive where things are just going upwards, flare, and then this is inflammation. So it's just inflammation is continuing to rise. So what's my goal? My goal is to manage the disease activity, keep the baseline inflammation down. Okay? And then whenever I have flares, manage my flares. Okay? And then the goal is to prevent end organ damage, specifically to the joints. Because once the pannus is developed, it's tough. So how do I treat it? So I'll give you some very basic treatment principles. Again, we get them sent to rheumatology for the most part, but we give them methotrexate. That's the drug of choice. Okay. So remember with lupus it was hydroxychloroquine. With this one methotrexate is first. And then we add NSAIDs for inflammation. If they are having an acute flare, we corticosteroid them. with prednisone. Again, rheumatologists may add hydroxychloroquine or sulfasalazine to treat this. But again, remember when you think lupus, you think hydroxychloroquine. When you think rheumatoid arthritis, you think methotrexate. Okay. And then if there's severe symptoms that are not being managed by methotrexate, we look at biologics, which is monoclonal antibodies, and anti-tumor necrosis factor alpha. Again, whenever we are giving anti-TNF therapy, we're going to basically take out their immune system. So we want to make sure we vaccinate these people. We check them before we start therapy for TB. And if we find latent TB infection, we try to treat it. And again, we test them for fungus and any fungus infections in that area. Any fungal specific species that are in that area. Because if they have it in them, and we take out their immune system, they're going to get systemic fungal infection. Okay? So that's treatment. How would you know the treatment is working? Well, the baseline inflammation is going to be down. The patient's going to say, hey, I feel better. Have less joint stiffness, no inflammation. Okay? I don't have fever or other constitutional symptoms. I have better quality of life. When you do a CRP on these patients, you're going to see the CRPs down. Okay? So even though it's non-specific, it's a good marker for acute inflammation, and you're going to see that down. They're not going to have flares. Okay. Now, are there any complications to rheumatoid arthritis? The answer is yes. There's a couple that are really important that I want you to know. The first one is Felty syndrome. So rheumatoid arthritis plus decreased granulocytes, and again, neutrophils are the biggest portion of granulocytes. So if they're having decreased neutrophils or decreased granulocytes, granulocytopenia, and splenomegaly, then it gets a special name, which is Felty syndrome. What's the issue? Very, very, very high risk of infection. Very high risk of infection. So these are folks that may get admitted and maybe put on reverse isolation, where we try to protect them from infection from other people. So it's not them giving infection, the patient's giving infection to other people. It's the other people giving infections to the patient. The other one is atlantoaxial subluxation. So these patients sometimes present with upper extremity weakness. A rheumatoid arthritis patient presents with upper extremity weakness. The provider orders an X-ray and the radiologist says there's a subluxation in C1 and C2 joint. In a patient with rheumatoid arthritis, this may be due to pannus formation, and so this may lead to spinal cord compression. And remember that area of the spinal cord, if it's compressed, right, may lead to quadriplegia and death. So again, this is serious. So the provider actually may recommend a surgical consult where somebody may have to decompress the spine, remove that pannus. Okay. It may show up on the test where we're trying to intubate the patient, and the goal in that patient is not hyperextending the neck of the patient with rheumatoid arthritis. So we don't want to make it worse. Okay. So what are the nursing interventions? First, patient comes in with symptoms, we got to diagnose them. You can see how it can be an interesting diagnosis. A lot of times they get sent to rheumatology for diagnosis. Okay. Once diagnosed, we've got to look at baseline inflammation and knocking it down, and any flares and managing that. And we do that with symptoms and blood tests. And we treat it with medications. Well, I don't want to take medications. Sure. These are rough medications, these are tough medications, but if not taken, they may lead to deformities that are permanent. And again, complications that may be very severe. Okay? And again, we observe for symptoms in the joint and outside the joint. It's just a constitutional symptom. We talked about two complications, Felty syndrome and atlantoaxial subluxation, and then again medication and managing the medication for the patient. So that, in a nutshell, is rheumatoid arthritis. So in this lecture, we talked about how it is polyarticular, inflammatory, symmetrical, chronic autoimmune disease. Okay, we talked about what we think causes it, and it's type 4 hypersensitivity with anti-CCP antibodies. And over time, the inflammation leads to pannus formation in the joint, which leads to deformity. And then again, it eats up the bones and causes osteopenia. Systemic symptoms may include anemia of chronic disease, carpal tunnel, fever, rheumatoid nodules as big symptoms. Again, with some of the deformities, with the joints, it's small joints of hands and feet, spares the distal joints, or DIPs, again, swan necks, boutonniere's disease, and AM stiffness, morning stiffness for more than 1 hour. Found more in Caucasian women 40 to 50 years old. We talked about blood tests once the patient comes in, and x-ray that shore up our diagnosis. We talked about rheumatoid factor versus anti-CCP. Okay. We talked about the clinical course and the medications. Again, methotrexate and NSAIDs. Methotrexate for modifying the disease activity, and NSAIDs for knocking down the inflammation, and of course prednisone or corticosteroids for acute flare, taper, 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 as soon as we knock out the inflammation. Okay. And then if severe symptoms, biologics and anti-tumor necrosis factor alpha. And then we looked at Felty syndrome and atlantoaxial subluxation as two big complications for rheumatoid arthritis, and its treatment. Then again, we looked at nursing diagnosis, from diagnosing it to monitoring the disease course and flares, uh, and how we use medication to manage it and observe for complications. So that is rheumatoid arthritis.